All right, let's go ahead and get started. Welcome back, everyone, to our deep dive number 3. Hard to believe that we're here already and that it's officially March 1st today. Also a little scary to me that time goes by so quickly. But this is our social health data use cases and action deep dive. So to sort of wrap up this final deep dive in looking at, now we've talked about the data collection, the data storage, and then now what happens with that data. So I'm going to go ahead and do another couple of slides, PowerPoint slides, to do a little recap from our last deep dive. And then sort of set some objectives out for this deep dive before we get to having a discussion. So hopefully I can do this in a very smooth way. Here, hopefully everybody can see my screen okay. All right.
Yes, I can see your screen.
Perfect, thank you. All right, so just a brief sort of housekeeping that we've done in previous deep dives. This session is designed to be a conversational discussion centered around several key questions with the hope that this, as is our other deep dives, remain organic in nature and can lead in different directions based upon presenters and or attendees' emerging interests and needs. The attendees, which are different from our presenters, our attendees are muted to prevent background noise and disruption to our presenters, but our attendees have access to both the meeting chat and QA functions. So for the chat, you're able to use this to provide any comments, any feedback, or request any follow-ups from either us here at HealthInfoNet and or our presenters. The QA functionality is used to pose specific questions to HealthInfoNet or our presenters today. We will, just like we have before, still keep the idea of a parking lot. If there are questions or topics that might need further discussion or a discussion at a later time, we'll certainly do that just for the sake of timing and how much time we have today to discuss our current topic. Attendees may be asked to share their organization's experiences through some poll questions around social health and or SOGI. We will obviously give you a heads up and make note of that. Those polls will come up on the screen. And while we encourage your participation, they are certainly optional to answer and participate in. So taking a look back to our previous deep dive, number 2 last week, when we were talking about data storage mechanisms, it was a really great discussion. I think we learned a lot out of that conversation. Presenter organizations talked about their different data storage workflows. Most of them were pretty consistent in nature, that there's folks in the office when we're talking about sort of the office setting, that patients complete the screening, their questionnaires with either an MA that transcribes it into an EHR, and then there are other clinical staff, whether it's whichever provider is part of that treatment team, that will review, validate, and add any additional documentation. Then there's also a couple of folks who are using a portal source. So having a patient log in to complete the screening questions and or any other questionnaire for social health information or SOGI information, and then that is immediately entered into the patient's record. For social health information, most of the presenters store all risk assessments or have a storage process for all risk assessments, which includes screeners, diagnoses, interventions, and goals. This is stored discretely. Interventions may be stored in non-discrete documents as well. Most presenters' organizations do not store social health or SOGI data separately or differently from other patient clinical information, except for in practice management systems. There was some discussion and conversation around concerns with sharing some of the sensitive social health and SOGI information via patient portals. where patient or guardians might be able to have access to it. So we did have some discussion around adolescents and being able to make some information that maybe they wouldn't feel comfortable sharing with a parent, but we're sharing it with their care provider, and folks being able to have access to it via the patient portal, and or with certain staff members that may not need to know that specific information given their role. Presenter organizations can share social health data and SOGI information with external partners. So that was sort of the closing conversation that we had, which was who folks are sharing the information with. Just as an aside, as we sort of wrap up this recap, for folks that are asking, just as a reminder, we are going to make all of these recordings for each of the individual deep dives available for folks once we have completed all of the convenings and our closing. And we will be writing up a report that we will also be sharing with users. So just something to keep in mind as you may or may not have been able to attend the last deep dive and are interested in that information, that we will make all of these resources available to folks once we are completed. And with that, let's move on to just sort of lay the foundation for today's conversation with a session overview and talk about some of the focus and objectives that we're looking to get out of today. So the purpose of today is to discuss how our HIE participants are operationalizing the use of social health and or SOGI information within the patient care or population health workflows at their current organizations. We are hoping to learn how these healthcare providers throughout the state are using the social health and SOGI information in their workflows, as well as identifying specific tools and resources used by healthcare providers to make the cross-sector referrals for their patients, and having that be accessible to assess person and community risk factors. So that is what we are hoping to get out of today. These are just a highlight here of our wonderful presenters who have agreed to join us today. Obviously, same folks from our previous deep dives, but just wanted to highlight Northern Light Health, Maine General Health, and Maine Health from our health system perspective. And from our FQHC perspective, we have Nassau Healthcare, PCHC, and Greater Portland Health. For those folks, similarly to what we have done in the past, just to save on time, but when folks begin to enter into the discussion for our presenters here, if you can just give us your name and your role at your organization, that would be greatly appreciated. So without further ado here, we have our great and wonderful presenters here for everyone to see. And I guess what I would like to do to sort of start off the conversation today is to kick it off with sort of, in my opinion, as a social worker, the perfect day question, if folks are aware of that. But to have you all think of, if you could envision sort of a seamless process around how your organization could connect with other similar or cross-sector organizations to share social health data, what would that look like? So if you could sort of put on your hats and use some creativity here, what would be sort of that perfect vision that you would have? And I know before, and certainly if folks get quiet, I can call on somebody, but I'm going to stay quiet for a second and see if anyone wants to start us off with that discussion question.
So hi, everyone. I'm Megan Arsberger with Nassau Healthcare. I guess just to imagine that dream world that Nicole outlined. Some of you might be aware that there's some work around a community information exchange, CIE, in the state of Maine. So I have to say, in the ideal world, when I'm thinking about patient care and all of this, it would be a situation in which we had the technology to connect the patient directly to a community-based organization or service provider who then actually can see some of the details of what is going on, and not just from a health perspective, but what's also even already been accessed from other community-based organizations, so that we're not trying to replicate similar services that maybe have already been done. And so just having that level of information sharing across our entire network and across our entire system would be the ideal world. Now, that's a lot of work and it doesn't exist at the moment. But if I'm in that perfect world that Nicole outlined, that's sort of what I would imagine. And then the ability to close the loop and say what's occurring and putting that information back in, so that we all know sort of the overall care and services that are provided at the patient care level. So that would be my dream world.
I share Megan's dream. At even a more fundamental level, I'd love to know that resources are actually available. If the housing stock were appropriate and transportation systems were better developed and food were more accessible, healthy food in food deserts, that would be ideal. I'd also like to see stigma addressed. When I was in college at Orono in the 70s and the 80s, we had a soup kitchen that was really good food, really affordable, and everybody went. Families with kids, faculty, and students who could, there was no stigma involved. So to the extent that we could ideally address stigma that poor people experience, that would be great. And then finally, to the extent that medical providers, behavioral health, and dental providers could recognize the role that social risk factors play in clinical outcomes, and really, in addition to the preventive service purpose of the visit, or the chronic care management, whatever the purpose of the visit was, that they could carve out a time to just address the fact that there are some resources available that will both address this acute need for food, housing, and transportation, but also ultimately improve your clinical outcomes. Sorry, Marty Sable. I work with Megan at Nassau Healthcare in Springvale.
Thanks, Marty. I appreciate that. Really great. Jess, I know you were taking yourself off mute. I'll give you the floor. Oh, we can't hear you. Oh, no. Sorry, Jess, we can't hear you. I know it looks like, I know you came off mute, but maybe for some reason. I'm not hearing you.
About now.
Oh, yes.
Sorry.
No,
I had
that's
it on
okay.
my phone muted too, so I was double muted. Sorry about that.
That's okay.
So I'll start over. I'm Jess Nailsnick. I'm the Director of Outpatient Care Management at Maine General. I was nodding the whole time you guys were both talking. I'm seconding all of that stuff. I think just to add to it also, more around collaboration would be an ideal world, but even confirming referrals. I know we struggle significantly with once we make a referral, and I'm sure it's a staffing issue, but we're calling organizations over and over and over again just to see, did you actually get the referral? Then let alone they're on wait lists for, neuropsych for a year and a half. So my ideal world would be you send the referral and someone says received and they're on the wait list. So yeah, just wanted to add to that.
Hi, I'm sorry. No, Anne, you can go. No worries.
Okay. I'll just keep the Maine General train going, and then I'll throw it over to you. How's that? So I have a little bit, maybe because it's budget season at Maine General and I'm working on budgets. It's hard for me to even think of an ideal world because I'm very much in the real world. So I have one real world example, and then I'll move to an ideal world. So I was part of our collaboration here at Maine General is working with the Maine Mom program, which is a program to support pregnant women and postpartum women with OUD and SUD. And I was on a call yesterday, one of the advisory group calls, and they were talking about something DHHS is trying to get going, which is getting closer to this world. I don't think it's, not ideal, but it's definitely moving in that direction. And it's called Treatment Connector. It's not up, I don't think, for public facing yet. And it also has a component, and I apologize, I can't think of the exact title of what they're calling it, and this isn't live yet, but it's basically like bed connector. That's probably not the exact right phrase, but it's like if you're looking for residential care for somebody, like say somebody, delivers, the child is removed by DHHS, the best moment for that person to get into some kind of support is like to go directly from one bed to another bed, like to get some residential support. And so they're unveiling this tool where you can see the availability throughout the state right in real time, like what their current exact status is. And I think there's a component where you can reach out to them as well. So that's not, kind of addressing everything we've been saying we'd love to have, but I think it's much better than sort of like having a resource list that may or may not be updated and calling people and waiting to hear back, so that I think is kind of exciting that things are going in that direction. And then the other thing I just wanted to quickly mention is as part of the Peter Alfond Prevention and Healthy Living Center, we're really trying to, this is ideal world because we're not there yet, but we're trying to reach out and work with community-based organizations in a kind of partnership where we would get more into that kind of closed loop referral system, working on like a social need. And we partnered with Spectrum Generations on the state grant that was just released to kind of, fund and promote that kind of cross-disciplinary kind of collective impact work. And Spectrum was awarded that grant. We're not, the main awardee, but we're supporting them, and that to apply for that, you had to, have a healthcare system partner. So we are that healthcare system partner. So there's that effort. And then there's also our effort within the endowment where we're really trying to make these intentional partnerships with community-based organizations and support each other and work on, a collective impact type of effort together. So it's not, it's not very well defined yet. We're just at the beginning stages of it, but I'm hopeful about it. So thank you for the time.
That's great. Thanks, Anne.
Hi, everyone. I'm Bridget DeFilippo. I'm a quality specialist over at Greater Portland Health. To piggyback off my fellow presenters with just, community resources and outreach and, closing referral loop. I think in my ideal world, having people meet our patients where they're at. A lot of our patient population are new Mainers, immigrants, refugees seeking asylum. And I think just having, whether it's an educational resource or a community-based resource, healthcare or not, I think taking into account the social, emotional, financial stress that comes with being a new Mainer and being an immigrant, just having people really consider those different factors in it.
Yeah.
And that is all for me.
Absolutely. I think that's great, Bridget. To sort of piggyback off that a little bit too, I think we've seen in the past at HealthInfoNet, some of our participants who I think too, I say this with a little, asterisk with COVID, but there were folks, particularly I think with Central Maine Healthcare, who were working really closely, even with, Androscoggin Home Care and Hospice, let's say, when referrals were made, staff were able to do a warm handoff with somebody in the hospital prior to them leaving the hospital, which had really great success in the fact that relationships were able to be formed with that individual prior to leaving a healthcare, system being in the hospital, and it led to greater success for those folks that were receiving in-home treatment services. So just being able, sometimes, and that's that obviously took a lot of time to cultivate and do, but to me, sometimes having a warm handoff to somebody and having that sort of connection made really helps to increase the likelihood of successful connections and services moving forward with folks. So certainly that would be something, and obviously, when we're talking about different sort of use cases, obviously that warm handoff can look, a lot different in various ways, and it's not always face-to-face, but just being able to make those connections early on can be really helpful for folks. So that would be sort of my vision of a perfect situation. But any other thoughts to sort of build on what folks have already said? Anne.
Hi, this is Ann Dew. I'm part of the clinical informatics team at Maine Medical Center. And one of the things that we're going to be looking to adapt in some of our future versions of Epic is being able to include some of those referrals that have already been completed. So that's information that we can share with external organizations, because that's not current state right now. So that way other people are familiar with kind of the risk and then the interventions in place. And it sounds like other organizations are also kind of using non-discrete information to document those interventions. So maybe that can be like a future state of sharing that kind of referral and interventions discreetly.
The PCH folks, sorry to put you on the spot here.
I was actually just thinking, can you hear me okay?
Yeah.
Okay, yeah, it's working this time. I was just thinking kind of to round out a little piece of everything that's been said already, especially the information sharing, having access to what's going on can really increase the trauma-informed care, I think. I think some of our patients get so burnt out on being asked the same questions over and over and over that having that kind of open availability to see and learn more about patients really help with the connection with them in general.
Absolutely. I know that that's definitely been brought up too in our previous deep dives. That is just a really important thing to keep thinking about, is that, folks are asked a lot of the same questions. And I think it definitely feels burdensome after a while to have to constantly retell a story, and especially if it's a story you don't like having to tell, or if it's associated with, with feelings. It's a really great point to make, Nisha, for sure. Any other thoughts?
This is Holly from Greater Portland Health. I really wish that our vendors were more open to this kind of sharing of information. I think there's oftentimes that our systems are the barrier at times for patients. Back in the day when EHRs were coming on strong and that sort of stuff, the language of which they used to write their programs and that sort of stuff was designed so that you could share. But then they started to become a little proprietary and all of that kind of stuff. So I think at times that EHRs are barriers for patients. And how do we get around that?
Well, thank you for my creative, experimental, open discussion question. Really great thoughts, really great feedback. Moving forward, I guess I'll sort of like take a step back a little bit. And Megan, hopefully you can be maybe the first to go here with my question. But I was wondering if you could, if we're kind of thinking about it, like starting from an internal perspective of information sharing, and then we'll get to more of like an external understanding of sharing information. But maybe Megan, you could speak to how information is shared sort of internally when talking about NASON and YCCAC.
Sure. So Information is shared, I think, like most people. So we have the patient care aspect of sharing information, but we also have what we call an SDOH leadership team that is made up of representatives from York County Community Action and Nassau Healthcare, so that that team is able to look at information and data across sort of the system and be able to use that for continuous quality improvement and trying to make sure that we're looking at systems and workflows in thoughtful ways based on what's presented in front of us. And so we have monthly meetings where we're sort of reviewing practices around how we're using, like how we're actually implementing our practices. So I share that because there's a lot of ways in which you can use information beyond just like the workflows themselves, right? So we also then, I think people know this from previous deep dive sessions, but we do diagnose patients with the social need. And then we use a referral specialist, kind of like I know Jessica mentioned, having to do tons of follow-ups on referrals. Our referral specialists are very busy doing those types of follow-ups. But our referral specialist sends information over to, we have an SDOH caseworker at York County Community Action. And that position will receive the diagnosis and then any other sort of notes from the provider that's relevant to the situation with the patient for patient care. We then, in terms of just the overall information sharing, though, our caseworker will conduct sort of further needs assessment on the social service side, document all of that, and then connect to any array of other community-based organizations or internal services at York County Community Action, or we even might have them work in a coaching fashion directly with that position. And our caseworker is the one who then does all of the follow-up with anyone that a referral was sent to, community-based organization or internally. And basically we'll draft up consult notes that we then upload back into NextGen, our software system. So the provider will have that information at subsequent encounters. So that's kind of just to share kind of the path of data sharing between, but we have basically like our referral specialists are definitely helpful in kind of moving the initial information over. But it really we've created a position on the social service side that's really collecting, kind of that follow-up information to close the loop on all of the referrals and provide that back to Nassau for uploading into the medical record.
Great. Others, and sort of thinking about your own internal process of once a patient has sort of been flagged, or actually I'll stop talking for 1 second and that I'll let Wendy go if you want to take the floor.
I certainly didn't mean to cut you off, Nicole. I was just lining up. So I'm Wendy Jorgensen. I'm the Director of Population Health at Maine General. And for those of you that have been with us from Deep Dive 1, we have an update where our process for transcribing our screening tool into the EMR actually went live on Monday. So that's our internal win. And so we're actually sort of, still working out the bugs and building out our reporting system, but the expectation, similar to others, is that the Z code would be assessed and added to the problem list. So it would be sort of made available to others on the clinical team. They would see the evidence of that on the problem list. But the team of us actually that is on the call today met to sort of talk about how do we want to sort of look at this data and to share it across departments within our organization and then also externally. And so our vision is to build a dashboard where we can really see, individual practices can sort of see the, prevalence of social needs within their practice, We talked about being able to look at it at the census tract level, to really be able to see, are there certain neighborhoods, where, the needs are greater. So it's exciting work going forward. We're obviously, just at the beginning stages, but I think that idea of being able to share that information at the patient level is certainly important. And so, for the referrals to the social worker and for our community health worker team, et cetera. But I think that idea too of just sort of the more global understanding of the population we serve will be super interesting.
Absolutely. Great. Thank you so much, Wendy. Any other folks? Start to talk about their internal process around sharing information.
I would just add that we've done it, I think, 3 times now, Marty. I'm trying to think, but we've worked with some larger, like sort of national evaluators and partners to just share sort of what Wendy was sharing, but we've given our information to do a little bit more of a deep dive into what's going on with the people, like the patient panel that we serve, and trying to tell the story behind some of that. So that's been another way that we've used the information and done some sharing that's been really beneficial for us. So for example, we actually looked at specifically Head Start families utilizing health center services and found that they actually had a larger no-show rate than the rest of the patient population, which was really interesting. And so it was really good for us to know that, because what's the story behind that? Is it that, especially if you have younger children, maybe you don't have as many acute health needs. So then maybe you're not prioritizing your appointments, or childcare issues, or, so it was sort of an opportunity for us to dive a little bit more deeply into some of those types of scenarios. And so it's another way that we've done some of that information sharing, is to work with, evaluators and others to kind of get a sense of what is the story behind some of these things.
Yeah. No, that's great. And I guess maybe too, that could be something to put out to the group as well around any processes that you've put in place, or processes that you would even like to put in place to sort of be able to make those connections, to sort of bridge what Wendy and Megan just shared. Around, now that you have this data that's available to you, are you able to make any assessments around needs, or has that impacted any organizational decisions as far as treatment decisions, or even resource opportunities or options that may have been created because of the information you've had? That's definitely a great example.
Well, 2 things here, I guess. I mean, just following Megan's observation about no-show visits. We understand that it's just really not within everybody's capacity to keep appointments. You just, yes, I'll do this next week at 11 o'clock on Tuesday, but then this doesn't happen. So it really clarified with us the need for walk-in services for our primary care patient panel, particularly for folks with a history of having missed a ton of appointments going into it. The other thing, not all of our patients agree that this stuff is a priority. I mean, folks will, be objectively homeless, screen, we understand from the screening, the prepared tool screening, that they don't live anywhere, but at the same time, that's less important than getting my Suboxone script filled today. And I don't really have time to talk with your case manager. So in cases like that, the intervention is much more, well, here's some resources, check out this brochure, and that it ends there for the time being. The diagnosis is made, the clinician has an opportunity to follow up 3 months later, maybe, but and not everybody's in, and folks, as no-shows go, we were very good about referring, but then when the case manager gets the referral, the patient really is not interested in putting the effort into addressing those needs.
That's another great point, Marty.
With our behavioral health program at PCHC, we use the prepare tool to guide any goal setting conversation. But just as Marty was saying, if they don't think that those are their biggest needs, then we don't need to put them in the goals, but we always kind of refer back to it. We noticed you put this, and this on the tool. What does that mean for you? And it kind of helps drive our priority when it comes to normal.
Well, can I intervene to raise a question that was put in the chat that I think goes along with this conversation, which is hearing what you're and Marty and Misha are saying around the patient not identifying these as needs, perhaps, but what happens, for example, when the organizations maybe aren't able to act on some of the social needs that are being assessed because of a lack of resources. So kind of the flip side. Curious if anyone has thoughts to share there.
I was actually just going to add to that, Chad, off of what Misha said. While we use it internally for our behavioral health and our care management programs to identify needs, that's definitely one thing that we've been looking at off of the number of times that we've used the prepare tool to identify a need. How often are we actually acting on those resources? So one of the things that we added into our EMR was we added a box to check that says food box given or food sources provided. So that way, if the prepare tool, if they're identifying food insecurity, then we are at least trying to keep track of how many of those instances in related to the same time of prepare and identification of the food insecurity, are we providing the food box? We're definitely providing the food box or food resources in many other instances, where we may not necessarily be identifying the food insecurity, but we're trying to tie those two pieces together for use of all of those programs. And it is one of the things that we're monitoring for as an FQHC. For our HRSA requirements, we have been required to submit the number of times that we're using the prepare tool and the number of times that that tool is directly providing information in regards to food insecurities, housing insecurities, transportation insecurities, and those types of things.
This is where I'm going to put a little plug in for partnering with community action agencies. Sorry, I have to do it. Because I think that it's really important that if there's a referral for, say, food insecurity or transportation, I mean, that's fine. But a lot of the times the challenges facing patients are so much greater than that one item, right? Like usually there's a wide host of situations or challenges being faced by that individual. And there are very limited community resources. And so all of the community action agencies in the state of Maine have adopted what is known as a whole family approach. It's a family-centered coaching model. The idea is that they work with families to sort of address all of the needs across the family and trying to meet those needs. I share that because it's just a recognition that, sure, maybe there really is no housing available right now because we all know that that's the case. However, if you are actively working with a coach in an ongoing fashion over the course of months and months, then you can be having other needs addressed as you continue to work toward that housing situation. And so I just highly recommend trying to build those relationships because there is a recognition that there aren't resources to address everything in the community. And it is unrealistic to expect, to always have sort of that magic wand to fix that particular situation for a patient. So I think what we're seeing or what we've learned, and we actually had to learn this ourselves through our processes, was that information and referral services are beneficial to kind of possibly putting Band-Aids on situations for patients. That's essentially what it is doing. And we sort of recognized we needed to have this caseworker position in place that would support people in an ongoing fashion over time, because they have really diverse needs and are complex. And so we really needed to have capacity to try to meet those complex needs of patients. And so I guess what I'm trying to say is, like, yes, information and referral, and looking at how can we connect to maybe some coaching resources or ongoing models that can support people when there aren't those immediate resources available.
Megan, building off of that, there's a question in the chat to you that asks around that position you're describing. What delays might be encountered as issues are referred and subsequently resolved with a referral or another action?
Yeah, it sounds silly, but one of the biggest issues is just having good contact information for patients. I know that sounds so basic, but people change phone numbers or move or things like that. And so sometimes you're trying to assist somebody and you literally don't even have the best contact information for them, which is really challenging. So that's one issue. Another issue is this problem, right? Of there is no really good resource for this particular case. And so it does sort of bog down the process, right? Because it's not like you can put in a consult note for the next encounter saying, yes, this person found housing, because it's actually going to take 2 years to find that housing, right? And so it does sort of create this longer queue wait list, so to speak, or people that you just have in process because the needs are complex and long-term. So I'd say those are two things. And then we do have, depending on the community-based organization, we have some really great relationships, but some of them are a little bit harder to work with than others. It just depends on the partner, right? And so some are a little bit easier and more forthcoming with, their sharing of information and updates than others. It just sort of depends on that partner, but we've realized how important it is to have those relationships. And I hate to say it, but it is at the individual level as well as organizational level. I know John at this organization will get back to me and support things. And so we've had to go to that level of building those relationships, even at the individual level.
Hi, everyone. I'm Brianna Horan. I'm a community programs coordinator for Maine General's Community Health Department. I work specifically in our food insecurity work with the practices. So I'll speak a little bit about the interventions that we have in place around the social determinants of health screening results, how we use this information internally right now, and how we would like to in the future. Is really to drive our strategy and our work so we have a better understanding of what our patients' needs are and who our patients are in the community. What are their defining factors around healthcare access and health in general. So, for example, using this information that we're collecting to strategize community health worker needs, other population health initiatives, and in the community health department, with the food insecurity work, we have a partnership with Good Shepherd Food Bank. We've been participating with them in the Community Health and Hunger program for several years prior to incorporating that screening into the social determinants of health larger screening. So we've got some years under our belt there, and that relationship gives us access to resources for our patients, emergency food bags, like Lacey mentioned, she has as well, and also referrals, informal referrals to community resources like food bank lists, and as well as an additional resource guide that we've created to help patients navigate things like the housing options, safety at home, domestic violence, and so forth. So we're also have a social worker in our care team, care management team, is another intervention that we have built in place to, again, further facilitate how to navigate those tricky, complicated systems, like Megan was mentioning, that is not straightforward. So those are the interventions that we have in place right now for taking advantage of this data.
Hi, this is Anne at Maine Health. One of the things that Maine Health has done recently is developed access for patients for a food bank. So in the former Greyhound station, they opened up in partnership with Good Shepherd Food to open that food bank as a food insecurity intervention. And in regards to screening and being aware if there's any interventions in place, that is one of the things that's kind of an ongoing thing to keep in mind. For example, with our diaper insecurity, different sites have different resources available. So we don't necessarily want to put the screening in place until we have a plan for interventions. So that is something we are keeping in mind.
Thanks, Anne. And I guess to maybe, move that a little bit further, now sort of after we've discussed a little bit about some internal processes, and I know some folks have touched upon, especially around the food insecurity piece, some connections that folks have made in the community. But I guess getting a better understanding of some of the relationships that have been made, some of the resources that are available in your areas, and some of that sort of external work that when you've made these referrals, what does that look like? So I didn't know either Bridget or Holly from Greater Portland Health, if you can kind of speak to some of the community outreach work and some of the relationships that you all have developed. What does that look like when you're making those community referrals for your patients and or clients?
I will take it away, Holly, unless you want to interject. So we are really in the beginning stages of our social determinants of health screening. We aren't fully operational with it yet. So we're still in the progress of really figuring it out. We do have some social workers and case managers, and we do have resources listed in our clinics. And we have community health workers that will do outreach to patients and try to connect them. But we're really in the beginning stage. So I think that's at this point really all I can share.
We'll be at the go live stage on Monday.
Yeah.
So, I just have I've really enjoyed listening to folks, and I love the idea of a dashboard. I love the idea of doing a deep dive into what I'm going to call the analytics of the information that we're getting to figure out things like your no-show rates and stuff. So I'm certainly going to take that back to Greater Portland Health, because I think that is definitely something we could use.
Absolutely. Now, Holly, is as far as when things go live, are folks, maybe the community health workers, reaching out and doing referrals? Is there a process for documentation, or how that, I know obviously sort of the hot topic word, closed loop referral, which has been mentioned, but is there a process or a way to sort of document it, that it would ultimately get back to the care team once, you are at that point?
Yeah, I like the idea of the checkbox kind of thing, like, food box given or whatever. No, we don't have those details worked out. As I've said before in these meetings, as a FQHC, we've had community health workers. They've been doing a lot of this work. We just haven't been doing it in a formalized prepare tool and all of that all along. So, we do have, like Bridget said, we do have lists for them to use. They are referring folks to things. We just need to tighten up that piece so that we do have this closed loop referral. So that will be all ongoing work that we'll be doing as we roll this out.
Well,
Oh, sorry, Chad.
No, go ahead, Anne. I'll go after you.
Oh, I just wanted to share one initiative that the community health department's been working on is a Salesforce platform, because as several of you have noted, the importance of trying to follow people over time and help support people over time. Because we're all complex beings, it's rarely a one-off. It's gonna, solve everything, right? So we have a central resource line in the community health department called the Hub that serves a big, a variety of needs. And we also have chronic disease self-management classes and healthy living classes, that kind of content. So the vision of Salesforce, and we're in a 3-year process, and we're in the second phase now. We were the first phase, is to kind of have a comprehensive approach. So like right now, it's the Hub calls and referrals and the evidence-based classes that are living in Salesforce. In phase 2, they're working on bringing in marketing and bringing in patient data from our scheduling and billing platform. And then, phase 3, like the ultimate vision would be that you could longitudinally support people because you could kind of see them over time. And if different entities were feeding the information in, you can have mutually reinforcing messages, right? So if we're working with somebody in a national diabetes prevention program, and then they go see their primary care provider, and the primary care provider can see that, they can say, "Hey, great, you've enrolled in that class. How's it going? Are you doing it in person? Or are you doing it on Zoom? What are you learning?" So that I think what I'm kind of hearing is that, it's a journey with people, and it takes resources and time. And how do we do that in a way where we continue to see staffing shortages, that face us on multiple levels? Like, how do we, I don't want to sound cold and like, how do we automate this, but in a way, how do we automate this? How do we make it so that it kind of flows, naturally? So
That's really cool. I love that. Yeah, that's a great idea. Chad, did you have something?
Yeah, so kind of building on Anne, and this might be a reach creating the connection, but Anne, it sounds like in some ways you're speaking about how to create that shared record that kind of tells one story once, so you don't have to keep going to different places to find it. And what I'm curious about is if you all have a similar location where you can go to find what resources are available in the community to make the referrals. So I know there's 211 Maine that has a resource directory. And earlier you mentioned that there's Open Bed System and the new service location tool that Maine Care and DHHS is promoting. And for Maine Health, you mentioned that Maine Health is making specific inroads through partnerships with food pantries. So I'm just curious, like when you make a referral, what type of resource bank do you look to determine where that referral is best placed? Is it, again, just based on prior experience, or is there some central repository that you go to?
From Maine Health perspective, I think the Find Help or community resources is one of the primary tools, and just internal Maine Health kind of referral options for like nicotine cessation, for example. And then there's also a number of tobacco cessation resources available throughout the state as well. So it is kind of varied what's out there. And now that you're mentioning it, it would be great if we could all have like a collaborative list of resources we could all take a look at.
We do have a couple of lists at PCHC that we've created internally. So we have a resources brochure that we give to our patients when we're opening them for either our behavioral health programs or our care management programs. But we've gathered information from around the community to be able to give that. Some of those we make referrals internally in the system to them, and then some of them are self-referrals as well. So along with that, one of the other things that we put together was a resource brochure specifically around congestive heart failure diabetes, COPD, those types of things that were resource specific. So it has information on there like online resources that the patient can look up. It has information on there regarding transportation if they're struggling as far as getting to appointments. And then it also has, food banks and food resources that are specific to the area that we may be working with the patient in.
And I'll just add on to that. I like Lacey said, we at Maine General did put together sort of a resource guide that we hand to patients that sort of covers, a lot of different areas. But, I think that's a great question because, even internally within Maine General, like Jess and her team of social workers and care managers, have OneNote, where they, have all of their different resources. And then, part of my team is the team of community health workers. And we had all these, file folders on our shared drive that, have different resources. And, one project that we're undertaking now is building out sort of a resource database in a SharePoint sort of format so that we can make it so that it's available to teams across the organization, but also be able to track like what resources have been used recently. So we know, that the information is accurate and updated because there's an opportunity to sort of, if you go to open a resource and, reach out to that number and you find out, well, they're closed or their numbers changed or hours have changed or whatever, that you can put in a little note, and we sort of have a person who's our coordinator of our community health worker program who's sort of charged with, kind of maintaining the resource database. So of course it's a huge project. And we do use Find Help. I won't say that we don't use it. I think the thing that's a little frustrating with it is sometimes when you go into Find Help and you just sort of put in a search term, you get these national programs or whatever that really aren't necessarily all that helpful in your local area. So, there are some challenges with it, but there is a lot of sort of duplication of efforts that is going on in this arena. So I think it's a great conversation to have.
So we intentionally created our position to have the caseworker largely because we knew that it wouldn't be best to have our providers or people who are focused on healthcare have to learn all of those social resources in the community. I mean, that's just really unrealistic. And so we decided that's part of the reason why we decided to have this position for a number of reasons, but it's one of the reasons. So our providers don't necessarily even need to learn all of the community resources. They just know I can send this to this caseworker who then can make sure that she's really knowledgeable about the local resources, and that's her job. And so that's been a really helpful, and because like I was saying too, things change so quickly and there are a lot of relationships involved with this as well. I think that that's something that we've seen that's working for us, is to have it work that way.
Megan, do you just have one caseworker?
So we have one who's sort of the central point person for all of the referrals from Nassau Healthcare. However, she has a caseload of 20, and then she triages everyone else to the services across the community. And then she follows up on what she has triaged.
So I'm going to riff off a question that's in the chat that I think kind of goes between Megan, your workflow with the caseworker, and Anne at Maine Health, what you mentioned around Find Help. And I'm just kind of curious the perspective around a referral system that's digitalized versus one that's maybe more manual, right? And the pros and cons of each. And the question specifically was asking, are digital platforms more administratively, technically burdensome to providers? And I think mostly the CBOs would be my guess. So I'm just curious, we're hearing two different perspectives on what, Find Help versus more of a position specific workflow. And if folks have thoughts around the introduction of find helps or other types of digital platforms that are used like that?
Oh, I would say one thing I didn't mention about Find Help is, and this is a feature that I really like, patients can access it on the Maine Health website, and they can also access it through My Chart. So that was another point I wanted to mention. It kind of goes back to that stigma conversation that Marty mentioned, where you can help yourself by looking for those resources. And then we also have like patient assistance line. So if you're not really able to utilize that tool yourself, there's a number that patients can call to find connections to community resources.
I'm also wondering, as I think about, Megan, you mentioning earlier about connections, and if I were to go back in time and sort of put my discharge planner hat on when I was doing that work, you know, it kind of, and almost too kind of speaks to what Wendy talked about, which is, you know, I think there's definitely a place and a great, you know, reason for using services like Find Help, like Anne just said, if that's more self-service is helpful. But to me, sometimes it's just nice to have sort of created those relationships in the community, and you sort of know, like, hey, you know, Susan at so-and-so is the person I reach out to, you know, at this organization to make sure that the referral gets done, and we've developed that relationship. But also, you know, have sort of a database to put in notes or things that are really important for anybody who's making that referral to know about, that maybe, you know, some of the folks, you know, whether, and I know, you know, sort of my naivete and not using Find Help directly or any of those sort of third-party resources of how you can sort of input information, but we know, you know, staffing changes happen a lot. So maybe Susan moved on to a different job and there's somebody else that's in her role, but nobody knows that until they try to reach out and you can't get through, or, you know, being able to collectively share that information to sort of save somebody from having to take the time and effort to, you know, make that referral. But even though, I think, Lacey, to your point, having different categories, is this a program that's a self-referral versus wanting, you know, only, I know there are some folks that specifically only take referrals from a healthcare provider. You know what I mean? Just having that sort of richness of time saving when you have all of the necessary components to make some of those community-based referrals, and sort of what does that look like too, if we're, you know, thinking of a perfect world vision of, you know, I think there's, you know, is there a possible way that both, you know, a community-based organization and a healthcare provider could input that information, whether it's, you know, directly from the organization, or if, you know, you've made a referral to that organization recently and the next person that needs to do it needs to know X, Y, and Z, and they're able to share that collectively amongst a group. Just wondering what folks' thoughts, you know, are on that, as you kind of think about maybe what you're already doing, or what that perfect scenario might be.
I do think that there is a need for technology. So I think that, to the original question, like, in fact, I think our process at NASAN is too manual. I want to see a little bit more like automation to support some efficiencies. And it would be great to have integration with, could you have 211 somehow integrate? I mean, the other thing to think about is 211, I don't even know how many full-time employees they have working year-round to update those resources, right? So it is a lot of work, is what I'm trying to articulate. Like, having resources and updated resources, a lot of effort and time and energy. And so if there was a way to build on sort of existing infrastructure and have some automation there, that's really great. That being said, to your point, Nicole, I think that there needs to be also a human element because of the complexity of the challenges facing patients and the relationships that we have with community organizations. And so I guess what I'm trying to say is, I think that there's room for technology to help facilitate things. And to your point too, maybe there is even room for some patients who feel comfortable to access resources themselves, if that's the level that they're at. I know for us, maybe it's different elsewhere, but Nassau Healthcare, we serve a pretty at-risk population, high-risk population. And so I would say the majority of our patients probably need more of that hand-holding approach, is what we experience where we are.
I would say Greater Portland Health is in that same boat. It is more of that personal touch, the hand-holding, language barriers, big time for our patient population.
I would agree with both of you. I think definitely, as I talked about the resources, that it's definitely been a lot of a barrier in keeping up with those because the resources change so often or phone numbers get updated. As far as other resources that we tried to put together, we were trying to keep a running list of all of the availabilities of assisted livings, any housing, anything like that was available. Our social workers and our staff often call on those every day. So we had one administrative assistant trying to keep a running list, and it changed so much that it was just very difficult to keep up with. So the staffing and the resources to be able to do that is trouble related to that as well.
Jess, did you have anything to add? I saw you go off mute.
I was exactly going to say that the ever-changing, especially during the pandemic, oh my goodness, like all of a sudden you have this great program, surprise, that's gone. Funding, like it's, I oversee navigators at our cancer center too. And so just oncology related, it's to see these funds that have deplenished that we've never seen happen before. So I just wanted to definitely add to that because the ever changing in the last 3 years is more than I've seen in my career.
Oh, that's heartbreaking for sure. But just even knowing, right, that it's not available so that you can move on to something else. I mean, things like we all know it happens really quickly, but just to go, oh, okay, that resource isn't available. Maybe they're on hold, you can move on to something else, saves, staff time, which is precious to begin with, saves them that just by knowing what's available and what's not available. For sure. Any other thoughts or feedback as we start to transition away from social health for a minute and start talking about some SOGI use case examples? So I want to give folks chat any questions or anything we need to highlight before we move on.
No questions, though we can end with a poll if you'd like.
Sure, let's do it.
All right, so this is for attendees. Let me fire it. Okay, so it's multiple choice. So if you're doing more than just one thing, feel free to click multiples. But the question is, what are ways that your organization is using social health information? These are high-level groups. So to inform patient care through inclusion of the information in an electronic health record, to inform closed loop or just typical referral processes, even if it isn't closed, to inform new analytics and reporting development, to inform advocacy of resource needs. If it's something else, throw it in the chat. And if you're not currently collecting, also let us know with a not applicable. So we'll just let folks take a couple more seconds to do this, then I'll show the results. Okay, I've seen a lull. So here, let me end the poll and show the poll. So pretty evenly distributed across the options here. The first two around to inform patient care and to inform referral processes have 64% apiece. Analytics has 45%, and advocacy and local is 55%. So thanks for letting us know. All right, Nicole.
That's great. So I just want, before we move on, I just want to say thank you. I think that was a really great discussion. I think we could probably continue discussing it for even longer than the hour here. And, you know, hopefully, you know, this work that we're doing right here is going to keep moving forward and pushing the conversation and the dialogue, and even the needs around additional resources here in our state for the individuals that we're working with. So thank you to everybody for that conversation. And with that, we're gonna move on to SOGI, and I know Anne, who's filling in for Brandy Brown today, who couldn't make it, has a presentation to share with us, and then we'll get into some continued discussion. So Anne, I will let you take it away.
Hi, yes, I'm here with Melissa Fairfield. She's the director at Maine Med, if you want to introduce yourself.
Yeah. Hi, I'm kind of subbing for Brandy today. With Anne, my name is Melissa Fairfield. I'm a nursing director of 2 inpatient units here at Maine Medical Center, and I've been involved in kind of our SOGI implementation of our tool. And then we're going to share an example of how we are using SOGI data to improve patient care.
Okay, I think I'm sharing my screen. Are you able to see?
You are. Thanks.
Okay, great.
I'll go to the next slide, Anne, and I'll start.
Okay, there we go.
Perfect. So in the past at Maine Medical Center, patients were roomed by legal sex only, and this created issues, especially for transgender, non-binary, and gender non-conforming patients. And these patients were often waiting longer because they were waiting for private rooms, which meant they had increased boarding times in the ED. And that puts them at greater risk for poor outcomes, and they're not getting the care they need in the place they need when they're waiting in the ED. Or they were sometimes placed into a semi-private room and the other bed would be blocked, which further strained our already strained capacity for our system. So we received feedback from patients expressing frustrations, staff expressing frustrations, and we also recognized that the standard of care for all patients really needed to be equitable. So this was something we needed to address. Additionally, the old practice was created risk for the organization with regards to our compliance with our own non-discrimination policy, as well as state and federal law. You probably know in 2005, Maine established LD 1196, an act to extend civil rights protections to all people regardless of sexual orientation, and that includes protection for transgender people. And under the Affordable Care Act, it's also illegal for most healthcare providers and organizations to discriminate based on transgender identity. So it was clear we needed to address it. Spring Harbor, which is another hospital within our system, had implemented a policy back in 2018 that roomed patients based on gender identity. And so we recognized in 2019 we wanted to do the same, but Spring Harbor and Maine Med are very different facilities, both in size and processes. There are 100 beds, we're 700 beds, and they have kind of a controlled admission process, and we do not. So the SOGI tool was added to our electronic health record in 2019. And then it honestly took a couple years to do all the edits to the tool, the education for staff, the policy approval process to have this rolled out. So you can go to the next slide, Anne. So it was literally years of working on getting the tool right, education, getting the policy through. And it was a year ago today that we implemented the new policy at Maine Med. And so the new policy rooms patients first by gender identity, and then secondly by legal sex. This slide is just kind of a piece of the education we used in our announcement and our messaging of the change to staff and to leaders. And we really focused on the why and on the need for equitable treatment and the need to be in compliance. We also created an FAQ document, which I think Brandy or Ann might have emailed, and we're happy to share that. It's a really great document, and it's attached to the hospital policy. And we distributed that widely when we rolled the policy out, but people can still access it through our policy system. And we've edited it multiple times to make sure we're capturing the majority of the questions that arose during the rollout. Next slide, Ann. So this is essentially an excerpt from the new policy. patient placement is now, it's based on sex and gender. Semi-private rooms are based on sex and gender identity. As we know, Maine, New Hampshire, both have recognized 3 legal sexes, male, female, and non-binary. So at the time of admission, patients will be roomed based on their gender identity field within the electronic health record. If there's no identity, no information in that field, then legal sex will be used to determine placement. And if the gender identity and legal sex fields are not the same, the patient will be informed as reasonably able that bed placement is based on gender identity and that they may have a roommate. As with any patient, they may request to wait for a private room to become available, and they will be informed of the potential delay in care as a private room may not be readily available. And then we added that once a patient has been roomed, changes to their gender identity can be made in the electronic health record. However, rooming changes might not happen after the admission right away, and we can do our best to make a reasonable effort to make the appropriate room change. And so we worked hard to train a lot of the ED staff on how to use the SOGI tool. And our goal is to try to capture this data on all admissions. We're not there yet and can share some data about where we're at the end of this. But I do think staff are really good at trying to add the SOGI information if that info is shared with them or if they recognize that it could impact patient placement. And do you want to do the next slide?
Yeah, and this is just a snapshot of the tool that we're using where you can document the gender identity. So there's options available for staff to quickly document. It's also available for registration to document as well, in addition to the clinicians. And then again, it's available for the patient to document within MyChart. This is just an overview of the Epic tool that we've been using and some of the updates we made. So we updated the field to gender identity to display in kind of our summary reports for the patient. So because that's how you're planning the beds. And then we also pulled in a new column if legal sex and gender identity did not match for the planning staff to be aware.
Yeah, I think we recognized once we started capturing the data that we couldn't just use it as it was available in Epic. We still had to do a bunch of changes to make it to be able to operationalize policies based on the data capture. And so this was a big one because we have a separate department that controls all patient flow, and they need to easily be able to see how to room patients without opening the charts. So we had to make multiple changes to this so that it was easily visible to them.
And this is just a snapshot of what the new column looks like and some of the icons that will display for the bed planning staff, just to get a quick view of that.
So it's been, the policy has been in place for a year. It's actually been going very, very well. We know that we've had 44 unique patients with a documented gender identity of non-binary, transgender female, transgender male, other, or choose not to disclose who have been admitted since the policy was in place. We know we're not capturing all of our transgender or gender nonconforming patients either. Under our previous policy, though, all of those patients would have been boarding or waiting for a private room, regardless of the medical need for a private room. So it's been very successful for us. Southern Maine Med rolled out the same policy in June of last year, and the Maine Health system has adopted this for the entire system, but it's not been implemented at all sites yet. And then, and Anne could probably speak to this too, but we've noticed some challenges with data capture on how we have implemented the policy. There's no real clear way to tell what type of room a patient was in. So even though we know somebody's SOGI information, we can't necessarily easily see were they in a private room, did they have a roommate, were they in a semi-private room that was blocked? So it's hard to see if we've impacted some of the things we were trying to address in implementing the policy. And And then I think, Anne, we're only capturing data, SOGI data for about 17% of admissions, right? So we know there's a lot of opportunity still there.
Yeah, and in regards to reporting, I think one of the challenges is you're not just looking at the patient, you're looking at the patient's room or the presence of a roommate. So that's one of the challenges we've encountered. So that's still a work in progress. And then it is one of like the main health goals to work on the collection of gender identity information. So that's going to be more to come with that as well.
And then Melissa, I guess let's maybe open it up and see if any of our presenters have any questions for Anne and Melissa, or if there's any questions maybe to in the chat, or Liz, that we've seen. I think this is really great information. I'm really thankful that you all presented on this. So.
And Melissa, have you had any complaints since implementing the policy? That's possibly a proxy measure of its effectiveness.
Honestly, we've, knock on wood, I hate to say this out loud, but we've not had one complaint related to the rooming policy. I think we educated the people that we thought might get involved in issues the most. So a lot of education with our nursing supervisors. And then our charge nurses, nursing educators. Brandy has designed some education around simulation for medical students and medical residents. And so, and we use a patient complaint about rooming as an example in that simulation case. So she's discussing that through a sim with residents throughout the year. So it's just been a lot of education, trying to get people comfortable, and then talking through like what could potentially come up and how would you handle the situation.
Great. Any other questions?
There's a question in the Q&A section, and I think, Melissa, you kind of answered this from the rooming perspective at Maine Health, but in case other presenter organizations have a different take, the question is, can you explain how your organizations are training staff to make better use of patient SOGI info if available within the point of care encounters?
One thing I would add to that is we just are doing a lot of basic kind of EI education and just about respectful interactions and why it's important to have that information in order to have a respectful interaction with a patient.
Anyone, I guess, maybe to look on the other side of the coin too, around maybe looking for resources or looking for education. I think this is definitely something that I know we're hoping to work with Brandy on and other folks as well, just around what they might need for education and what resources might be out there for folks who might be struggling and don't know how to provide that education to their organization or staff at their organization. So maybe I'll put that out there if folks, looks like Anne raised her hand too. So I'll let you go ahead, Anne.
Oh, I just wanted to share that we developed a frequently asked questions document that Melissa mentioned. So we're happy to share that with other organizations if you want to kind of work through that education piece and some of the questions that come up from staff.
Yeah, that would be great. Thanks, Anne.
And it looks like there were a couple of questions in the chat. Melissa, and I just noticed your responses may not have gone to everyone, so I'll just restate them so that folks can see them. So this was a question for Melissa. So have you had any issues with the roommate patients being uncomfortable? Melissa responded no. And then the next question was, have your staff been trained on how to respond to those concerns? And the response was yes, especially nursing supervisors and nurse leaders. Melissa, was there anything else you may want to add beyond that?
No, I would just second what Ann said about the FAQ document. We'd encourage, if you're thinking of implementing this type of policy, just making sure that the education is the most important piece, and we're happy to share that.
Would you say, I guess, a question to folks, to our participants here, are you finding that your patients are looking for more SOGI resources in the community? And I'm wondering too, maybe specifically parents or caregivers who might be looking for more information, if that's been something that folks have seen. I'm just kind of curious just around what folks have been looking for or needing from a patient perspective and or a guardian caregiver perspective. And even folks to maybe some of our attendees, if you want to put anything in the chat too as well. I'm just curious.
I would say and I don't want to speak for Brandy, but based on the number of referrals and the significant increase in the number of referrals to the gender clinic at Barbara Bush Children's Hospital, I think there's definitely a need. And I know that, again, not speaking for her, but a lot of times it maybe didn't require a referral, but there's discomfort with a provider and discussing things with the patient or the family. So it ends up getting a referral. So I think education could help that as well.
Yeah, and Greater Portland Health has a gender affirming program as well, with a provider who has done I would say a fair amount of training with staff, but I think that's an ongoing process. But yeah.
Yeah, I know that. I mean, and particularly, obviously, the rooming discussion is obviously geared more towards a health system perspective than an FQHC perspective. But one of the really great things I think about and Melissa's presentation is even for folks that aren't doing that specific work because it's just not applicable to their organization. I think it's really helpful for folks to know that that's what's happening. So if there is, any concern or apprehension when folks are getting healthcare, that you can speak to what folks are doing in their community, maybe around rooming, that just helps to maybe ease any anxiety that they might have about receiving care. So I thought it was really important and crucial to kind of share and let folks know that that's what's happening at Maine Health. And hopefully, definitely something can be replicated too amongst others too, because it sounds like it's really been, even in its very sort of infant stage, really helpful for patients, even in the year that it's existed. So
I'd love to have a copy of the FAQs, even though Maine Med and Greater Portland Health are very different entities, but still, I think there's always learning that could be done.
100%. For sure.
From prior conversations, Greater Portland Health, Nassau, and Maine General, we heard that you all are collecting SOGI data elements in some form. And so if it's not a rooming policy like what Melissa and Ann showed us from Maine Health, curious if or how you all may be using the SOGI data elements that you are collecting within patient care workflows, if at all right now.
As part of the Salesforce project I mentioned, we did build in the demographic section gender identity into our hub and classes programs. And then for our harm reduction program, which operates 2 syringe service programs, they have quite an extensive list that really includes the non-binary pansexual. I mean, it's a very extensive list because that best helps that population feel like they're being respected. So it's a much more extensive list than we have in our other section in Salesforce.
Yeah, if QHCs are obligated to collect first the categories of sexual orientation and gender identity, we do that. We have sort of another category as well for folks to get very, very specific. I'd like to say we do a whole lot of work with that, that data, but I don't know that we really do. I think services are really delivered on sort of an individual basis. If a person requests something like gender affirming therapy, if taking the sexual history shows that the person has a lot of different sexual partners, that will sort of suggest ways of doing preventive work or addressing needs that patients are identifying. But that specific data point, those specific data points, I don't know that they really drive a whole lot.
I'm wondering, Lacey or Misha, in thinking about the Bangor area and sort of northern Maine, eastern Maine, if there are resources, in that area, or if you're finding that it's a struggle to identify any of those when we sort of think about the eastern and northern sections of the state.
I think we definitely have some of the same struggles with resources in that regard. We are trying to work, very closely with other, community entities as far as the city of Bangor, the state of Maine programs within care management and those types of things to identify better resources in regards to, housing specifically. I know that has been a struggle. And there's been some goals to try to get, the overabundance of the homeless population off the streets right now. So we're trying to pull together as many resources as we can around that at this time. As far as other resources, I think it just comes down to having the resources available in the community and then having the staff resource to be able to make these things happen or spend the time to find the resource.
I think another way to phrase it too, and Lacey, you were kind of getting to that, I think in a way, was coming back to Nicole's question around the perfect day, right? Like, even though currently maybe there's hopes for doing more, what would be the ideal state for use of SOGI data within your workflows? If you have any thoughts there, I'm just curious.
I think that's an overall comfort level of staff working with that type of data. I think that's one of your huge amount of barriers is they're already working with these patients on very sensitive issues as far as social determinants. So addressing the SOGI data and being comfortable enough to have those discussions with the patients and still be on the same level of their openness to being able to help them with the resources and working with both the social determinants plus the SOGI. I think we have a long ways to go internally at PCHC as far as using the SOGI data. We've tried to work to collect it as best as possible, but I don't really think we have a good flow of using that data so far.
Yeah, and I would echo with Lacey. Absolutely, we don't have a good workflow, but we try to use them at our Bridge Clinic, at our Hope House, the clinics where we have, this kind of population or the challenges. So we try, but for the timing, we don't have a good use right now. Yeah.
And I'm sure you're not the only ones, in that space too. I think some of the, things that I think about, and know that we touched upon this in the previous deep dive. And I think the data speaks a lot, in many ways, but one of them in particular is obviously, needs assessments for your communities, and where there is a complete lack of resources, referral sources, and so on, that can really help to drive that, information and those needs, to at least identify them, to say, we know based upon what we're hearing from individuals and their own needs, this is where there is, a lack of resources for them. But definitely a way that the data can help bring to light what's there and what's available, and what's not, at all. And even, thinking about Jess, and her mention of neuropsych evaluations. I mean, that brings me back to of my days, clinician days, and to think that folks wait on waiting lists for, upwards to a year to get services is really hard, to know that that's what's out there and that's what's occurring, even though we know that need is there.
Yeah.
Sure.
And Nicole, just to add one more point, like we don't have a good workflow, but we try to use these data for applying for a lot of grants. Related. So we have that in place. I work with the grants team for example, colorectal cancer screening, for exact sciences, for different grants. We use this data to apply for that. And sometimes we get it or not, but yes, absolutely. This data is being used in different forms.
Yeah, no, that's a really great point, Bilal. I'm really glad that you brought that up.
Yeah, and I think that's definitely where you need to start. You need to start with capturing the data first, because the barrier is having, like we've all talked about, the staff or the resources to use the data. So if we gather the data first and then we apply for these grants, like Bilal said, then hopefully we can get more help or more resources as far as staff or designated people to work with these things. I love some of the ideas that have been discussed as far as, SDOH coordinators and those designated type of positions, because when you try to mold this work into all of the other things that all of our case managers or our staff already do, it's very difficult.
That's a really great point, Lacey. Others, thoughts, feelings, feedback? Do you have any other questions? Chat in the chat.
No other questions, but maybe now is a good time for the second poll question, because it kind of builds on top of what Lacey was speaking regarding comfortability of using the data. So curious what attendees think to that end. So let me go back here and launch the next poll. So the question is, do you think your organization could benefit from additional education on how to use SOGI when it's available at the point of care? And so, yes, my organization could use additional education. No, my organization is comfortable in the use of SOGI info, or not applicable. So we'll take a moment to let these come in.
Chad, it states that host and panelists cannot vote.
Yes, this is good question, Bilal. This is for the attendees, and then I'll show the results of the poll here in a moment. I think I've seen trickle end here. So end poll, share results. So 40% of attendees who answered say yes, my organization could use additional training. 30% no, they are comfortable with the current state, and then 30% are not currently using SOGI information. All right, thank you.
I guess I will, since we've had a little lull in the discussion, maybe put it out to folks as sort of a final call for any of our attendees if they have any particular questions for our presenters, and see if there's anything else that maybe we didn't get a chance to discuss that you want to sort of put out there before we start to wrap up for this afternoon.
I would just comment about the SOGI data, that for the gender identity field, the highest user that's entering that data is actually the patient themselves. So if you have an opportunity to have the patient self-enter that information, they do enter it. So if you have that opportunity, I encourage you to promote that.
That's great, Anne. Thanks you. That's a really good point for folks.
I know the rollout was just at Maine Med and SMMC. Are you rolling it out to your primary care practices as well? The collection of that data? Of the SOGI data?
Yeah, the primary care practices have access to SOGI, and I can't tell you the percentage that's done there. Anne might be able to tell you that. I think they may be better.
Yeah, I don't know the percentage off the top of my head, but it's still an ongoing kind of work. So we still have work to do as well, because the goal would be to collect it on all the patients.
I think Brandy had said maybe in the first deep dive that she had done some particular trainings with the ambulatory practices. So maybe still kind of also in its infancy, but it sounded like those folks were at least trying to start to gather the information, if I remember.
Yeah, I think that's accurate. It also has to do with the comfort of providers. I'm sure certain providers are using it probably a lot more than others.
Yeah, great point.
Just an observation, we find that folks are much more comfortable discussing or reporting on SOGI information than on their financial picture and their other social risk factors. But we get great SOGI data, but not great financial picture for our patient population.
Wow, that is really interesting, Randy.
I think sometimes we struggle with, are we asking like the PSRs to be asking the gender questions, or are we asking the providers to do it and then input it into the system? This is where this whole education piece comes, and it's awkward at the front desk. It's a front desk, you know? So I think that's what we're.
Yeah, there's good information out there on how patients prefer to have the information collected as well.
Yeah.
So, yeah, we've done a lot of research on that. And then we talked about having registration collect gender identity data, but Epic does not allow them access to that field. And so it is a clinical conversation.
Our patients fill out a paper form and then registration staff key it into the system, key it into NextGen. Practice management, Holly.
Yeah, we actually, the provider that runs the program developed a new questionnaire, if you will. So we're working off of that now, but still, if she happens to go see people at other sites, those people haven't been trained, and so it just gets a little messy sometimes. That's all.
Yeah.
And on the PCHC side, we are having some discussions about collecting SOGI data using our ClearWave, our kiosk at the entrance. So that is something what we are brainstorming on, based on privacy and a lot of other factors being involved on that. So that can be also a good option if somebody is using a kiosk. It's quick, it's connected to our EMR, and there's a flow there. Yeah, just a thought.
Great. I didn't see any additional questions in the chat.
Nope, I think we're good.
Okay, so it looks like we can give you some time back, but before I do that, just a couple of quick things. One, to just sort of reiterate that all of these deep dives have been recorded and will be made available to folks once we've completed the convenings, on top of a report that we are going to finalize. So with that, let me just really quickly share our timeline here. Hopefully you can see that okay. So now, gosh, we've come a long way in now completing this final deep dive. So the next two things here to kind of talk about is for us to do sort of a presenter debrief discussion with our presenters, with the plan of doing sort of a closing and a next steps on the social health data action plan, which is scheduled for March 29th from 12 to 1. So certainly all audiences are welcome to attend that, and we will sort of wrap things up really nicely for folks and discuss next steps and where do we go from here. So definitely we'll be sending out more information in regards to these last two sort of action items on our overview here. So you'll be hearing from us shortly. If there's any questions from either any of our presenters and or attendees, you are obviously welcome to outreach to us. And on behalf of the HealthInfoNet team, Lainey, Liz, Chad, and myself, I just want to yet again really thank our presenters here on this panel, and for any of those folks that obviously joined us in previous deep dives. We know your time is precious. You're doing absolutely incredible and amazing work. And so we really just want to thank each and every one of you for taking some time out to meet together, to share, hopefully grab, some ideas from folks and learn a little along the way. And we really hope to carry this through and continuing these discussions beyond this convening as well. So thank you so much. We really appreciate it, and we hope you enjoy the rest of your day, and you'll hear from us again shortly.